An earache might seem totally harmless, right? But when a chronic infection really digs in, the physical complications can actually be devastating. Welcome to this explainer. Today, we're breaking down the precise medical complications of CSOM, or chronic suppurative otitis media. Okay, let's dive right into this by outlining our agenda. We're going to move systematically through the exact data, covering 3 main sections. 1. Extracranial complications. 2. Intracranial complications. And 3. Critical management. Starting right off with Section 1, extracranial complications. These are the conditions that happen outside the brain cavity. Take a look at this specific sketch of the inner ear for labyrinthitis. This acts as our first visual map for the anatomy we're dealing with. So, what's happening with labyrinthitis? The cause is infection spread. For the pathophysiology, toxins literally enter the labyrinth, causing severe inflammation. Clinically, because this area controls balance and sound, you're looking at intense vertigo, nystagmus, which is involuntary eye movement, nausea, and hearing loss. The treatment here is an oral toilet and heavy antibiotics. Now, what's really interesting about this next sketch is seeing exactly where a thrombus, or blood clot, actually sits right there in the lateral sinus pathway. This is lateral sinus thrombosis. The cause, again, is infection spread. The pathophysiology is straightforward. The infection directly leads to thrombosis. A blood clot forms, and clinically, this triggers an intermittent fever, severe chills, a pounding headache, and papilledema. Before we go any further, let's actually quickly define pathophysiology since we're trekking it closely today. Simply put, it's exactly how a disease process works, develops, and affects the body's normal functions. Let's see how this builds. Here are 2 sketches side by side illustrating the progression: temporal bone caries on the left and an extradural abscess on the right. Let's break down the exact text. For caries, the pathophysiology involves osteolytis and necrosis. The chronic infection literally destroys the bone. Clinically, this causes persistent discharge and cranial nerve palsies. For the abscess, the pathophysiology is pus collecting right between the dura and the bone. Basically, that bone erosion lets a pocket of pus collect outside the brain lining. Moving on to Section 2, intracranial complications. The barrier is breached, and we are now moving inside the brain cavity. This brilliantly illustrates meningitis. Notice the inflamed, highlighted linings, the meninges, completely surrounding the outside of the brain tissue. For meningitis, the cause is the spread of infection through bone defects. The pathophysiology is a direct infection of the meninges, the brain's cover. Clinically, this manifests as a severe headache, neck rigidity, fever, and photophobia, and extreme sensitivity to light. Immediate IV antibiotics are absolutely critical here. Strictly looking at these cross-section sketches, we can visually anchor exactly where pus collects in both extradural and subdural abscesses. Notice the difference in depth. Here's the exact pathophysiology. With an extradural abscess, pus collects between the dura and the bone. But with a subdural abscess, pus collects deeper, between the dura and the arachnoid mater. Because it sits deeper, it causes direct neurological deficits, or nervous system problems. Visualizing these specific locations is the crucial point here. We have the sketch for an intracranial lateral sinus thrombosis, and right next to it, a highly localized brain abscess. A sinus thrombus causes papilledema and fever. Meanwhile, a brain abscess is localized pus deep inside the brain parenchyma itself, which causes distinct focal neurological signs. Both require heavy antibiotics and surgical drainage. Focus clearly on this final sketch. This shows otic hydrocephalus, beautifully illustrating the impaired absorption and accumulation of fluid right inside the brain. The primary cause here is a blockage of the CSF pathways. The pathophysiology is the impaired absorption of cerebral spinal fluid, which leads directly to dangerous accumulation. Clinically, as the fluid builds up, the patient presents with a severe headache, vomiting, and drowsiness. And finally, Section 3, critical management. We have reached the most important takeaway at the very bottom of our medical chart. Here is the key point, verbatim. The most dangerous complications are intracranial. Early recognition and aggressive management are essential to reduce mortality. It's a stark reminder of just how critical it is to treat these ear infections early before they ever have the chance to breach the brain.